Hi, everyone. I'm Dr. Jenna Raymer, and my colleague and partner, Dr. Mindy Christensen's on the call as well, too, if you want to say hi also.
Hi, everybody. We're very excited to teach you about egg freezing tonight.
Yeah, so we have a presentation that we're going to go over. We've just put together some slides. This is some of the bread and butter of what we talk through every single day in our clinic with our patients, Dr. Christensen and myself. But we put together some slides just to kind of make it a little more streamlined. And we're going to start off with the first half with Dr. Christensen going over what is egg freezing, why to consider egg freezing. And then towards the end, I'll wrap up with what that actually looks like here at the clinic and following up with a REI or fertility doctor to talk about this. So I'll hand it over to you, Dr. Christensen.
Great, wonderful. So let me just see if I can advance my slides. Okay, now it's working. Here we go. So egg freezing, you may also hear it called oocyte cryopreservation. Oocyte is another name that we may refer to your eggs, and cryopreservation is another word for freezing. This has become a really popular option. Egg freezing was considered experimental until 2012, and after it was no longer considered experimental, the volume of egg freezing has really increased in the US by over 1,000%. Between 2009 and 2016. There are many patients, trying to advance, but there are many patients that can benefit from egg freezing. We often perform egg freezing for patients who have medical conditions whose treatment could be harmful for their fertility. This includes patients who are undergoing chemotherapy for cancer treatment, or patients with medical conditions such as lupus or rheumatoid arthritis or sickle cell anemia that require treatment that can be harmful for their fertility. There's also gynecologic conditions like endometriosis that can be harmful for fertility. And some patients have what's called primary ovarian insufficiency, which is also called premature menopause or losing the eggs at a young age. Probably the most growing group of people who are freezing their eggs today are those that are delaying their family building until they're older. They're realizing the impact of age on their fertility and freezing their eggs. And that's something that we often call planned egg freezing. So there's also patients with cancer. I don't know why these slides are not advancing easily. Let me see if I could just click. With cancer that can be affected by fertility preservation. The American Society for Clinical Oncology actually recognizes fertility preservation as a key survivorship issue. Okay, so what we're also seeing is a lot of patients are delaying their family building until they're older. Since 1970, there's been a 900% increase in women over the age of 35 waiting to have their first child. In fact, over half of women with a college education will be over the age of 35 when they have their first child. Okay, let me. And so also fertility does decrease as you get older. And so we often see this, especially in patients over the age of 35, and it really drops off after the age of 37 where natural fertility decreases. And also what's really important, and we show this slide to all of our patients when we see them in clinic, at least I do, is that females are born with a set number of eggs. So the highest number of eggs that a female will have is before they're born. They'll have 6 to 8 million eggs at 20 weeks gestation. At birth, the female will have 1 million eggs, and then that number of eggs goes down over time. And we usually see a larger decrease in the egg supply around the age of 37. And then also, unfortunately, egg quality goes down and the number of eggs that are chromosomally abnormal increases with age. And so we see a higher rate of miscarriages as a woman ages. And so that's another reason people decide to freeze their eggs. And when we look at fertility treatments, so for instance, IVF, the age is a big factor in the success of IVF. So the older a woman is, or the older her eggs are, the lower the chance of having a live birth with fertility treatments such as in vitro fertilization. And so there are many reasons why women are choosing what we call elective egg freezing or planned egg freezing. They may be delaying family building status due to partner status or due to their career. And they also may want to increase their chance of having a biological child when they're older. There was an interesting study that was done that actually looked at the cost effectiveness of egg freezing. And what they did was they looked at women who froze their eggs at the age of 35 and compared it to women who waited until they were 40 and did IVF at the age of 40. And what they found was that it was more cost effective for someone to freeze their eggs at 35 due to the higher chance of live birth until waiting until they were 40 and doing fertility treatment. So egg freezing was considered experimental until 2012. It took many years to develop because the egg is the largest cell in the human body and it has the most water. And so ice crystals could form with egg freezing. And so they had to develop a special type of freezing technique called vitrification, which is flash freezing of the eggs. And so with vitrification, the eggs are cooled very quickly to negative 196 degrees, and they're actually vitrified, which is stored in a glass-like state. And as I said before, it was considered experimental until 2012, but it's no longer considered experimental, and it's become a very popular treatment for people. The best candidates for egg freezing would be those that are having menstrual cycles. And so if a patient is young and hasn't started having menstrual cycles, they would not be an ideal candidate to freeze their eggs. And ideally, if someone were to choose the ideal age, it's before the age of 30, but ideally between 30 and 35 if they're doing it for planned purposes. And if someone had a medical condition that was harmful for fertility, to be able to delay that medical treatment 2 to 4 weeks. Patients that would not be good candidates, or people who would not be good candidates, are those that do not have 2 weeks to wait to do the egg retrieval if they have to have medical treatment, and if someone hasn't started having menstrual cycles. And so next we're going to have Dr. Raymer, and she's going to talk about, if you are considering freezing your eggs, what's next and what are the steps?
Perfect. Thank you so much, Dr. Christensen. So that was a really great overview of kind of the history of egg freezing and why people choose to do egg freezing. And we see within our clinic all of those different reasons, from patients with sickle cell anemia to truly just doing it for elective fertility preservation due to their career or spouse status. So it was a great overview. So I'm going to jump into talking about what does it look like if you were to come to kind of see us with a plan for freezing your eggs. So a little bit about how to prepare for your visit and what to expect at your visit, in addition to how the egg freezing process happens. All right. So we're going to talk about having some goals for your appointment, kind of the overarching time frame of how long does this process take. And then a little bit of information about, coverage through insurance, employers, and things like that for fertility preservation. Okay. So I think the most important thing that we want to know as your reproductive endocrinologist or your infertility doctor is to first kind of understand what your goals are. What are your plans? What is the ideal family size for you? Because for somebody who knows right out of the gate, they've only ever wanted to have a single child, that's going to be a very different way that we're going to approach egg freezing compared to somebody who knows that they for sure want 4 or 5 children. And so we're going to have different goals for that individual for the total number of eggs that we'll need. And we'll go more into that in a little bit. And then also to talk a little bit about the ideal timeline, right? So to give a couple of theoretical examples, if I have a patient who is in her early 30s and knows that she would like to ideally wait for a partner before she starts to have children, and it does not have a long-term relationship right now, it's most likely going to be on average somewhere around another 4 or 5 years before that individual is probably ready to start having children. By the time they are settled into a relationship and have some time together, and then to choose to start building a family, right? So we're looking a little bit into the future. Versus if somebody comes to me in their early 30s and is already in a relationship and has plans to get married, next year, and is wanting to have their first child within 2 years, that individual probably is less likely to need fertility preservation because they're more likely to be able to achieve their goals without the need for fertility preservation. So the timeline of like starting and continuing to have children is really applicable to like whether or not we choose to move forward with fertility preservation. We're also going to want to know some things about your basic history, like past medical history, prior surgeries, whether or not you have any comorbidities or medical problems that we'd like to know about. Some of your genetic history and family lineage is important. And understanding what's going on with pelvic organs. So we often do a pelvic ultrasound to look at the uterus and ovaries. And then there's going to be some blood work and testing that is going to help us to be able to counsel you better. So some things that patients can do to kind of optimize fertility in general, which also plays into the health and quality of their eggs long term, is things that overall are considered to be good health. We think of these things in general, right? But avoiding nicotine products, excessive alcohol use, other drugs, well-balanced diet, achieving and maintaining a healthy body weight, physical exercise, and then avoiding things in the environment like pollutants and hormone disruptors are helpful for overall fertility and improving your egg quality as a whole. One of the tests that we frequently order on our patients, and we have a lot of patients ask us about when they come to their first consultation, is ovarian reserve testing. Oftentimes they'll ask for an egg count, and that's what they're referring to when they ask for that. This test is called anti-Müllerian hormone, or AMH. And anti-Müllerian hormone is a hormone that is put out by all of the eggs that are left in reserve in your ovary. So the higher this number is, the more eggs there are in reserve, and the lower the number is, the fewer their eggs are in reserve. This level, this hormone or lab level, really helps us predict the quantity of eggs that are going to be available for us to take every single month a woman goes through an egg stimulation and egg retrieval process. But it does not predict the quality of those eggs, okay? So it's important to remember that. So people can have, you know, a very high AMH level at the age of 40 or 42, but we know that the quality will be poor of those eggs because of age-related declines in quality. Whereas somebody may have a few eggs at 30 and the quality is much better. So it's just a predictor of the number of eggs. All right, so the follow-up consultation. So you've seen us for the first visit. We talked about your history, your goals, and we talked about getting lab work done, and we've done the AMH testing. So with this visit, we're going to talk a little bit about the results of all of that workup, your ultrasound, your labs, and we're going to go into a lot more details about the egg freezing process, all right? So let's discuss results to start with. I hinted a little bit already about why AMH is important, but what I want you to kind of see over the next few slides is why it is important to us. So if the AMH level comes back as low for your age range, or even in your age range, a normal level, but low overall, it may mean that we get fewer eggs from you from a single cycle of egg retrieving than we would from somebody who has a higher level of AMH. And so patients need to be prepared mentally and emotionally for the possibility that they might need to undergo more than one egg freezing cycle to get the ideal number of eggs in the freezer that they desire. So then the question becomes, well, what is that number? How many eggs do I really need? Well, there's a lot of things that factor into this. We have a lot of data and fancy calculators we can use to help you understand that better. But it really takes into account the following factors. How old are you when you're going through the actual process? Because we know the egg quality declines with age. What is your ideal family size? 1 child, 3 children? And trying to figure that out. And then also the goals for egg freezing. Is it really to ensure that you're just having one future pregnancy or multiple future pregnancies, which plays into the same as ideal family size. So this is kind of a graphic representation of why the number of eggs matters. And it's not perfect. It's you know, it was done by somebody else, and it has, you know, kind of the overall big picture. And I think it's helpful to kind of see this and to put it into perspective. But the take home message here is that 1 egg does not equal 1 baby. All right. So if we look at women on average who come to us for egg freezing, who are under the age of 35, on average, we're getting around 15 eggs from a single cycle. When we take these eggs and we put them into the freezer, Not all of these eggs are going to survive the thaw process, all right? So eggs are a lot more fragile than other things that we freeze, like embryo or sperm, because they are larger, like Dr. Christensen talked about, and they're a little more challenging to freeze. We do a really good job at it these days compared to the way it used to be, but it is still a challenge, such that only about 80 to 90% of those that actually go in the freezer will end up making it back out of the freezer, right? So we lose some eggs and come down to about 10 to 12 eggs for every 15 that go into the freezer. And then we have to fertilize them. So these are being used in the future, and they need to be fertilized with sperm, either a partner sperm or donor sperm, to achieve an embryo. So they become fertilized. The fertilization process in human biology is also not 100%. It's only about 70 to 90%, depending upon, which lab is doing it. And then once an embryo has become fertilized, not all of them are going to make it to an embryo. It has to grow for 5 days in our lab and culture media. And we see a loss of the embryos growing from the day they got fertilized until the day they're ready to go back into the uterus. And this just happens naturally in human biology. And once we actually get to an embryo, depending upon the age of the individual whose eggs we used whenever we put them in the freezer, it will help predict whether or not that embryo is going to be chromosomally normal or chromosomally abnormal. And only normal embryos, for the most part, are going to stick and become a successful pregnancy, leading to a live birth. So you can see we can start with a very high number of eggs and get down from 15 to 1 quite quickly, right? And not every single embryo that's chromosomally normal will stick and become a successful pregnancy. So this is why we need a high number of eggs to start with, to give a better chance at getting that single pregnancy you desire. But now let's take a woman who wants 3 children, right? So we're going to need even more eggs at the beginning of this process to end up with the correct number of embryos. And then what if you're over 40 when you're going through this process? So women who are closer to the age of 40 are going to have eggs that are more likely to be genetically abnormal right out of the gate. So we have a decrease in quality. Dr. Christensen showed that with the miscarriage rate. So miscarriage rate goes up because the quality of the egg has gone down. So you're going to need even more eggs to be able to get to a normal, genetically normal embryo that we can put back to create a pregnancy. So most of our individuals who are over 40, really truly even over 37, are likely going to need to undergo the egg freezing process more than one time to get the number of eggs they desire in the freezer. So this is a great little picture if you guys, have the ability to screenshot this or take a quick little snap with your phone or whatever, but it breaks down. This was published in one of our highly reputable journals. And it looks at the number of mature eggs that an individual is going to need to be able to have at least 1 child, 2 children, or 3 children. So let's look at this first one up here in A. If you're between the ages of 30 and 34, and you want at least 1 child, if you end up with 10 eggs in the freezer, you've got a 60% chance that you're going to have 1 child from those 10 eggs, okay? So that's how you read these graphs. And then you can kind of look at what that means to try to get to 3 children based upon your desires, and seeing how those numbers decrease over time, especially in our category down here and group D between the ages of 41 and 42. We see that even with 30 eggs in the freezer, you haven't even reached a 60% chance of pregnancy. So for the first child. So more eggs needed for the older that a woman is. And that's why the younger we freeze eggs, the better. All right, so follow-up consultation, we talked about the results, we talked about what to expect based upon AMH. Now let's talk about the egg freezing process in detail, okay? So this entire process from start to finish really takes, for most, at most 2 weeks. It's an average of 8 to 14 days, okay? There's going to be daily hormone injections that you give yourself, anywhere from 2 to 3 medications that you administer yourself at home. These are very easy to give. It's a very tiny little needle that goes right underneath the skin in your belly. You pinch up a little skin on the belly and inject it right below the skin. And you'll be doing this daily. And during that time, you're going to be coming in for frequent ultrasounds. Over the course of the 1 to 2 weeks, most have around 4 to 6 ultrasounds. And at each visit that you come in for an ultrasound, you're also going to have blood work to test hormones that are being put out by the eggs. And once we determine everything has grown to the perfect size, you undergo an egg retrieval. So this is kind of like what we're seeing on the ultrasounds. We go from having an ovary with very small little bitty egg follicle cysts located in them. And then from here, we give injections and they grow to be quite large. Okay, so these are mature follicles that most likely have a mature egg in them. And then this is a graphic just kind of showing how the egg retrieval process is done. For us on our side of things, this feels like a very simple routine procedure. For you as a patient on your side of things, you are coming to our IVF suite where you're being taken care of by our IVF procedure nurses who are very fluent in doing this. We take you to a special room that's connected to our embryology suite and you go to sleep with sedation. So this is like a very kind of deep twilight like sedation. It goes in through your IV, you receive medication that drifts you off to sleep where you won't feel or remember anything, but are really only asleep for about 10 to 15 minutes max. This is a very quick procedure for us. And so we go through the vagina with an ultrasound, which you can see here. And the ovaries are sitting quite large and low next to the vagina. And we have a tiny little needle that pokes through the top of the vagina and right into each one of these egg houses. And we suck out the fluid and the egg comes with it. All right. And then you wake up and recover with us for about an hour and you go home the exact same day. And our eggs then go into the embryology lab to get frozen. So making a treatment plan is also part of our conversation that we have. And this is where we talk about when do we want to start this? What's the right timeline for you and the dosing of medications that we're going to use and overall like chances of success on a single round versus needing multiple rounds, kind of everything we talked about just now, kind of in a summarized kind of a treatment plan for you. So in conclusion, the things that I think that Dr. Christensen and I really want to make sure individuals take home from this, and then we'll take some time to answer any questions that came in that we haven't covered, is that we really want patients to understand that fertility does decline with age, and that the optimal time to do egg freezing is before the age of 35. But even if you're over 35, now is better than never. So we would prefer, even in our patients who are 37, 38, 39, come see us. We can talk through it, talk about your chances of success. Egg freezing can be done for many reasons, both medical and non-medical. So what we consider like fertility planning or elective fertility preservation. It's a very safe procedure with good success rates. And we will make sure as your fertility team to make sure that your treatment is being tailored specifically to your individual needs. Anything else to add, Dr. Christensen?
No, but we would really welcome any questions that any of you have, because I know there can be a lot of questions that can come up and it may seem like an overwhelming process, but if you do decide to pursue freezing your eggs, we're with you every step of the way and we'll walk you through the process. And so it may seem complicated, but we will make it very simple.
Absolutely. We have a couple of hosts that are on this call with us who have been helping us screen questions as they've been coming in. Are there any things that you guys can see in the question list or things that we may not have talked about or got to during this presentation?
Yeah, I think from the submitted questions, you covered success rates by age. So that was great. Were there any side effects of egg freezing that weren't covered?
Do you want to take that one, Dr. Christensen?
Sure, absolutely. So kind of going through the process, how you feel will depend on your response. But usually your ovaries may be 2 to 3 times the normal size because you'll have the follicles growing where the eggs are developing. So you may feel a little bloated during the process. And also your estrogen levels in your blood can be up to 10 times or even higher your normal levels. And so estrogen is generally a feel-good hormone, so people feel good, but you may feel a little bit more sensitive. So you may be watching a television commercial and be teary and not sure why, and it's due to the estrogen. Sometimes after the egg retrieval, people can develop what's called ovarian hyperstimulation syndrome. It's usually mild cases and it's something we watch for very closely, but that's when your ovaries can start to release fluid and you can be very bloated after an egg retrieval. And so that is like one of the complications that we watch for very closely and we help manage.
Great, thank you. Another question was, can the PGT be done before or after egg freezing?
I'll jump in on this one. So that's a great question. So PGT, for those that aren't familiar with that acronym, stands for pre-implantation genetic testing. So we do offer PGT testing here at the Cleveland Clinic for a lot of our patients, but that testing is only done on embryos. We cannot do genetic testing at this time. The technology doesn't exist to do genetic testing on individual eggs, right? So in order to do genetic testing, we actually have to take some of the cells away and send them out for genetic testing. When we're dealing with an embryo, it is a multicellular structure that has hundreds of cells within it. So taking 3 or 4 cells from, say, the placental tissue of the embryo does not affect the overall embryo. We can send those out, find out if the embryo is normal or abnormal genetically. But when we're dealing with an individual egg, if we were to sample the egg's DNA to send it out for genetic testing, it would destroy the egg because it only has one copy of that DNA. So we're not able to run genetic testing on the eggs, but once the eggs have been fertilized and grown into embryos prior to implanting them back into the uterus, PGT testing is available. Not every patient is a good candidate for it, so that would be a conversation we would have at a future date when that time came to decide if it was the right thing for you.
Thanks, Dr. Raymer. And then I think the only other question was, can the time frame the eggs stay viable?
So there is no time limit that we're aware of as far as how long, eggs can be frozen. We know from our experience with frozen embryos that embryos can be frozen and produce some viable pregnancies and babies after 30 years of freezing. And there's no reason to think that the same wouldn't apply to eggs. So there is no time limit on storage of your eggs after you freeze them.
Thank you. I don't see any other questions in the chat. But again, we did record this and we will be sending it out to all the attendees. So thank you for your time and thanks for the presentation, Dr. Raymer and Christensen.
Oh, I just saw a question.
Oh, we got one last one.
I just saw a question about insurance question mark. So yeah, so a lot of insurances will cover fertility preservation when it is under the umbrella of a cancer diagnosis or the need of some other type of medical treatment, and you are hoping to preserve fertility before you undergo this medical treatment that can be harming to your fertility. We see a lot of insurances that will choose to cover it for those reasons. But even then, there's still a good handful that don't cover it for that reason. And there are grants and other things out there that we can help patients apply for to be able to receive both medication and coverage for the actual treatment. A lot of organizations will also offer what we consider like a compassionate discount to patients who are undergoing, something like cancer, to be able to get their eggs frozen as quickly as possible before they undergo that treatment. What we see less of, however, and we wish, at least I know I do, and I can probably speak for Dr. Christensen as well too, is that we wish insurances would cover what we consider more of the elective fertility preservation. Women who are choosing to delay childbearing for, social reasons and have a reason why they want to delay that maybe isn't necessarily a medical treatment. And we just don't really see that being offered kind of across the board, at least not here in the state of Ohio. Now, there are some locations and some job companies that will offer to cover it. So we encourage everybody to look into their own individual insurance. Most of the time you can call the number on the back of your insurance card and ask to speak to somebody who is a fertility advocate within the insurance company. And they'll be able to connect you to somebody who really understands the fertility benefits that are offered by your particular insurance. And then I'd also encourage you that anytime there is open enrollment going on within your, within your company, within your insurance plan, to also look and see if there's different tiers of coverage, because some will cover fertility benefits while others may not. But here we see a challenge with a lot of companies not offering this. So many patients have to pay out of pocket for egg freezing.
Yeah, I agree with what Dr. Raymer said. There are more and more companies that are recognizing the advantage and the benefits of planned egg freezing and are starting to cover it. And so especially if you work for a larger company, it's definitely worth looking into the benefits.
Thank you both. Any other questions?
Just one comment on cost, just to kind of say for those who don't have cost, of course, it's very individualized, right? So I can't give you an exact number as to exactly what it costs because it depends upon the amount of meds you're going to need, the number of cycles you're going to do. But I typically tell my patients on average to expect somewhere between 10 to 15,000 to go through a single cycle of egg retrieval to freeze eggs. And then of course it depends upon how many cycles you need and the medications you're going to take. But just to give a ballpark for patients who are curious as to what that number looks like.
That's good. Thanks, Dr. Reitmer. Okay, I don't think there's any other questions. So if you two don't have any other notes that we haven't touched upon, I think that concludes our presentation for today.